So welcome everybody to the final Bander Center event for the 2018-2019 year. I'm pleased to see all of you and thank you for showing up. It's great to see you. So the Bander Center for Medical Business Ethics is an ethics center that's housed in the School of Medicine at St. Louis University that focuses on education and research about issues in medical business ethics. It was established in 2007 based on a charitable grant from Dr. Stephen Bander and the BF Charitable Foundation. We have an educational mission, a scholarly arm, and we put on events like this one. My highest hope is that this event and all of our events inspire you to take something forward, a new project, a new company, start something new. I'm Jason Kuhn, the Executive Director of the Bander Center. So I'm thrilled that my guest today is Dr. Sonny Saggar. Sonny was raised in West London and attended medical school at the University of Oxford and London. So Oxford preclinical and London clinical. He took out a couple of years to explore other career options, but decided that accountancy and investment banking were not for him, so he recommitted to a medical career and finally graduated as a physician in 1995. After a few months traveling around India, Singapore, and finally Brisbane, Australia, attending to the underserved Aboriginal population in the outback, Dr. Sagar immigrated to St. Louis in June of 1997. As with all foreign medical grads in America, Dr. Sagar had to repeat his postgraduate training in America, which he did in internal medicine at St. Luke's Hospital in Chesterfield, graduating in 2000. From 2000 to 2017, he worked initially full-time and then part-time from 2010 as an emergency physician at multiple hospitals in St. Louis area, including St. Luke's, MOBAP, Christian Northeast, St. Charles Health Center, St. Mary's, St. Louis, Lake St. Louis, Progress West, Barnes West, and St. Alexius. While at St. Luke's, he served on several management committees, including peer review. He served as chairman of emergency medicine at St. Alexius for 2.5 years, and during that time, he became very familiar with all the other physicians as well as the financial operations of the various hospital departments. Dr. Sagar founded Downtown Urgent Care in March of 2009, against the advice of many pundits who told him it would never succeed. The medical facility now boasts about being the only urgent care in St. Louis that is truly urgent, in that it is open 24/7, and one of the few that has true access, in that all patients are welcome, including those patients on Medicaid and Medicare. Sagar is loud and proud as a social justice warrior and does not believe that certain things should function as businesses because they involve the well-being of humans. Areas that he feels should not be guided by capitalist models include healthcare, education, law, and other, including prison reform. So now he's 51 years old. Dr. Sagar seeks only to do what is in his power to achieve universal health care in America. Until then, to do whatever he can to make sure that those in the coverage gap get care. So Sonny, welcome to the Bander Center. Thank you very much. Let's kick it off this way. Okay, can you give us a little background? What is Downtown Urgent Care anyway? What kind of services could I expect to get if I were to go there? What is it?
So it's an urgent care. So we can do all the acute care stuff. That doesn't necessarily mean it's an emergency, but if it is an emergency, then we have an ambulance bay out front. We'll stabilize the patient, put them in an ambulance, and send them to the appropriate hospital. But in terms of acute care, most urgent care is, minor problems which are not life-threatening or limb-threatening or sight-threatening. Yeah. So we can do X-rays, EKGs, blood work, nebulizer treatments, IVs, we drain abscesses, suture up lacerations, set fractures and dislocations, drain abscesses, and if there's something that we cannot handle, then obviously we either refer to an outpatient specialist like you, or we send them acutely to an ER.
Okay, something like that. So, what about, do you get the sense, what is an urgent care doing in the whole framework of healthcare? There's a doctor's office, right? Open on Wednesday afternoon, right? There's emergency room where there are traumas coming in, and it's this big, humongous place. It's, urgent care is somewhere in between those two, right?
What role does it fill?
Yeah, what role does it fill?
Yeah, it's kind of good for nothing in some people's eyes, but I think it does serve a very useful purpose. Especially in a country where you have to think about your copay, where you have to think about the bill if you haven't met your deductible, where there are other people who have more serious conditions going to the emergency department. Do you really want to distract the doctors and nurses in that ER from strokes and heart attacks and people getting hit by trucks with your sore throat or your UTI or your minor issues? And a lot of people cannot get in to see their doctor in an acute manner. So they can call their doctor's office and they'll say, yeah, I'll see you next Monday at 2 o'clock. Well, you know, my sore throat might be better by then. My UTI might be better by then. And so should that patient go to the emergency department? Absolutely not. That's just silly. And so that's why we thought, I've always felt that not being 24/7 was, I mean, we've all heard the arguments why urgent care. I mean, everyone's been getting those mailers and the TV ads and the radio ads for the last 15 years, but nobody addressed what happens after 8 p.m. So acute problems don't happen after 8 p.m. apparently. People don't get injured after 8 p.m. And so I thought, well, that's kind of silly. We should just be open as much as the emergency department. And so I think it does serve a useful purpose for minor emergencies, if you will.
Something like that. So downtown urgent care is a little different from most urgent care in that it's open all night. I mean, that's one thing, right?
Correct.
I mean, most urgent care is not open all night.
No other urgent care in a 200-mile radius is open all night.
What other ways is it different?
Well, I'd like to think that, I mean, I don't think that's a fair question, because I think a lot of urgent cares have very good staff and very good people. So I'm not going to claim to be an expert on how other urgent cares
go in their clinical.
But maybe, I think what I can say is things about us. So one of our mantras that I teach all our doctors all the time, and all our medical assistants and all our junior staff, is always, if you're not sure what to do, treat that patient like you would if they were a member of your own family. So your mom, your dad, your son, your daughter, your niece, your nephew, your grandpa, whoever. And whatever comes to you is most likely going to be the right answer. And I think the flip side of that coin is, you know, the only parameter which really matters as when you're choosing where to go for your healthcare, whether it's a hospital or an urgent care or an imaging facility, is whether the employees at that place would actually go to that place. And so it's the same thing. You know, treat everybody like you would your own family, and would you go to that place yourself? I think it's the same answer. And that's one thing that I think makes us different. We don't look for the money. We actually, I refuse to let my doctors know what kind of insurance or lack thereof the patient is on. Because it should not be a factor in the decision making ever. Because that's a recipe for disaster.
Got it. Wow. One thing you do is to accept a lot more insurances than a lot of urgent cares might do. Is that so?
Right. So we accept.
You might not know what other places do or whatever, but you accept a lot of insurances, right?
We accept all private insurance. We accept cash. We accept Medicare, Medicaid, TRICARE, and yes, it is true that there are many urgent cares that do not accept everything, especially those payers on the poorer end of the spectrum.
One more thing about downtown urgent care. Do you think just about urgent care in general, if there was no urgent care, do you think people would more go to their primary care doctor or more go to the emergency room? What are you offloading?
Well, it's an acute setting. If your doctor can't get you in, then most of the time the doctor won't be able to get them in unless the doctor's got after-hours surgeries, if you remember those days. Most people would go to the ER. And if you recall, 20 years ago, we used to have problems with ER overcrowding and overboarding, and that was the big problem. Well, nobody talks about that anymore because it's actually been addressed by the urgent cares, except in the middle of the night, where sometimes at SLU ER or Barnes ER or Mercy ER, you will have a 6 or 7 hour wait. But that doesn't usually happen during the day anymore.
Interesting. So I've seen this slide of yours that you have made, and it shows on one side of the slide, it's kind of like the spectrum of sickness across one axis, right? And on the far side, on this side, everybody who is pretty much well, and they've come for care, but they're pretty darn good. Hardly anything's wrong with them. Everybody from that category is sent home, right? And then, pretty much.
If it's mind-blowingly obvious to everybody present,
that the
patient
patient's
included,
fine.
that the patient's going.
Yeah, right. And then on this side, if it's like the sickest possible patient. All those patients are going to get care, right? And then you've got this you've got a gray area, right? It's colored gray. You know what I mean? It's that gray area in between, and you can you explore that space, that in-between space?
So I use this model for teaching a number of different things, but in this context, for today's talk, you have the green area, which is you're green, you're good, go home.
Yeah.
Maybe you need an antibiotic, maybe you need a course of steroids for your poison ivy, maybe you need something like that. And then you've got the red side, which is an aortic dissection or acute meningitis or a very toxic patient who's in shock, and who obviously needs, they've got a leg falling off. They obviously need to be hospitalized, and something needs to be done. And everybody present, patient relatives, doctors, nurses, everybody will agree what's red and what's green. So if you've got the gray area, that is where the problem is in healthcare. So if you go to any country, socialized healthcare or private healthcare, the green areas are obvious, the red areas are obvious. It's the gray areas that are the cause of a lot of angst. And so what I've observed, and I think it's an unspoken thing amongst many doctors, so I hope you don't shut me up here, is that if the patient is in the gray area, then if they have good insurance or they have good coverage or they have good ability to pay, there seems to be a predisposition for the doctor to do more tests and do more procedures and just do more. And his defense would be, I'm going above and beyond the call of duty. I'm doing as much as I can for this patient. But interestingly, if that patient doesn't have good insurance or has no insurance or is on Medicaid, for example, then I'm not saying that the doctor does nothing, but they will suddenly have this adherence to the criteria, the published checklist of what you should and shouldn't do. They definitely won't go above and beyond the call. Unfortunately, and I'm generalizing, of course. But I've noticed that doctors don't. We seem to have a bias towards doing more rather than doing better. And doing more isn't necessarily doing better. And patients are actually part of the cause of that problem. Because if you send a patient home empty-handed, you can bet they're probably going to be upset and they're going to go find somebody else.
Or go somewhere else,
And so there's a level of expectation. And I know I'm preaching to the choir here, and anyone who's medical listening is probably thinking, yeah, that's true. But we're not going to change the world. So there are certain criteria that we need to adhere to, is basically the point of that green, red, gray area thing. And unfortunately, we don't adhere to the criteria. I mean, there was a New England Journal of Medicine study from Harvard in 2010, which said that 25% of all patients seen have suffered from a medical error. I was trying to be diplomatic from the way I said that. And so, and I think the cause has been identified as people not adhering to criteria. And if you could just stick to the checklist, you don't, when I first came to America, I was working, even though I was at St. Luke's, I did an elective at Barnes, and I presented a case. I still remember it vividly. A lady bumped her head on the garage door as it was coming down. She was fine. She had I'm going to bore everybody with the criteria. She had no amnesia. She was not intoxicated. She had no distracting trauma. She had no history of seizures, no seizure that day. She had no headache. She was not older than 65. She was not vomiting. She wasn't on blood thinners, and she didn't lose consciousness. Okay, and I went and told the attending, and I said, so I think she can go home. And he goes, are you kidding? She needs a head CT. And I was like, what? This is having trained in England. If you're going to scan her, you're going to scan everybody. And he said, yep, that's what we do. I was totally shocked. And I realized that, she had this nice thing called Blue Cross Blue Shield, which I didn't understand what that meant at the time. And I was like, this is the reason. Now, partly it's insurance and partly it's defensiveness. You could also blame the lawyers for all of this as well.
There's a big soup there,
Yeah,
right?
so
I mean,
there's
it's not the
a
only
this
thing
is a
like that,
big,
but-
huge subject, but
Yeah,
I mean, I'm just
yeah.
getting to the basics behind it.
Let's just switch the gears. I think, so social entrepreneurship is in the title of this event. That was my language. I don't know if I've ever heard you say that. You know what I mean? But what do you think? So social entrepreneurship is like using the mechanisms of business to create some kind of social goal, maybe something like that. I'm really interested in that aspect of downtown urgent care in this project that you've undertaken. I mean, would you call it this? I mean, social entrepreneurship. I mean, can you call it that? If not, what kind of thing
I think
is
this
it?
is good. I think all entrepreneurship actually tries to address a need.
Yeah.
And so in that sense, all startups are social entrepreneurs.
Yeah.
But I think when you have, in the optics, a very clear good being delivered to
Yeah.
the public, then, if the company is also making money doing that,
Yeah.
then so be it.
Yeah.
And we can all think of certain examples where that happened, but we can also think of examples where nobody's benefiting and people are just making money.
Yeah.
And so I do enjoy, I guess because of my background in the financial world as well as in the medical world, and the conflicted nature of my identity as a teenager, I think I wanted to do something where I could make lots of money. Even though I call myself a social entrepreneur, I even call myself a socialist.
Uh-huh.
I am also a capitalist.
Uh-huh.
I do believe in making money. I do believe in making profits, but I don't think anybody should be harmed in the process. On the contrary, I think people should benefit as a result of that. And that is why I started the urgent care, because I didn't like. I mean, it's good that you listed all those ERs, so I don't have to single one out.
Yeah.
But I didn't like how certain priorities were being addressed, where the profit motive was the number one priority rather than patient outcome.
Yeah. Oftentimes, so you use the word optics. I like that term. I think that's a term I've heard you use before. This is a place we go to in the Bander Center with some frequency. So the optics, the way it looks, you know what I mean? The way it kind of, the way this, maybe for-profit entity, is it just lipstick on a pig? Or is it when you make yourself look you can't, there's no way you can make yourself look right.
No, I think
without being right.
I think actions do speak louder than words,
Yeah.
or actions
Yeah.
do speak louder than optics,
Yeah.
if you will. I think saying that we're cool, we're great, we're good is one thing, but if other people are saying it about you, I think that's far more effective.
Right.
So, I've always had a problem with advertising in that regard.
Yeah.
I always felt, coming from England, where I don't know if they do it now, but when I was growing up, it was considered very unprofessional for doctors and for lawyers to advertise their services. And then I come over here and I see Brown & Crouppen everywhere, and I see SLU billboards everywhere, and I'm thinking, I guess this is the way it's done over here. And but then, you also have to make ends meet as a business, and I hate to use that word in healthcare, but unfortunately you do have to pay the electric bill, and you do have to make payroll, and so that's why a pure socialist system cannot survive.
Yeah.
I will say that you have to get the money from somewhere, taxpayers, but you have to address the for-profit nature of it. Having said that, you can still be doing good.
Yeah, interesting. So you're not a government, right? And you're not a university. But this one day, you just decided to open an urgent care in the middle of, what might be considered an underserved area. It's urban St. Louis.
Still is.
And it still is. And decided to accept all these insurances that don't reimburse very much, right? And you're talking about Medicaid and, no insurance, and underinsurance or poor low insurance, right? So this is a strange thing that you've done. It's not like there are lots of these, right? And so what made you want to do it? I mean, why did you do this?
That's a good question. I think I can feel my wife chuckling there. I think sometimes you have to ask yourself so I drive to work on 44 every day. I live in Wildwood, and it takes about 45 minutes. And At least once a week, I see a big car crash on the other side of the roads, and you pass by, everyone's rubbernecking. And I have come to the realization from that, as well as from being an emergency physician for many years, that that could be me.
Yeah.
And I think if all of us go through life considering today could be my last day. And I think not enough people consider that possibility. Then I think we might live a bit differently.
Yeah.
I think without, I think I remember telling my wife about 10 years ago, look, I know I'm crazy, but as long as we always have food on the table, as long as the kids will always have clothes on their backs, as long as we go on vacation once a year, could you let me do what I want?
Right.
And she said, sure.
Oh, yeah. Yeah, thank you.
Which was easy.
Good. Yeah.
But I think I get a real kick out of doing what I do. And and I feel like it's not as, I don't feel it's as charitable as it feels normal. To me, it feels like I'm doing something that's good. Yeah. It just feels like something I enjoy. I think I enjoy life. It keeps me from getting depressed or anxious or having high blood pressure, and it helps me sleep.
Right, I got it.
So I enjoy it.
Did you get a grant?
No.
Did you ever get a grant to do this? Are there grants to do something like this?
If there are, I wish I'd
We'd
known.
known about it, right? Exactly. It doesn't seem like. And so I also heard that you did this without taking any kind of a salary, right? Did you really not take?
Since we were a for-profit and now since we're a non-profit, I've never taken a wage.
Yeah, interesting.
As a W-2 or a 1099.
But your employees do.
Yeah, of course.
Yeah, I mean.
I don't think you could expect people to show up for work too long if you didn't pay them. But I don't know. My accountant pointed this out to me about 3-4 weeks ago, that it took me 10 years to realize I wasn't getting paid for this.
Yeah.
But I think I don't know. It's weird because I get paid from doing consulting work.
Yeah.
And luckily I married a girl from South City and we're pretty frugal.
Yeah.
And we live within our means, let me put it that way.
I think I'm interested in the replicability of this model. You know what I mean? Every time I, talk to you about it and think about it, I'm like, man, if we could just get this going everywhere, because it's a successful model. So let's talk about the successful model, right? So you've been in this business for 10 years, and you can't survive that long if you don't have a functioning business model, right? So, you don't take part of the day-to-day leadership of Downtown Urgent Care more, right? Did you tell me that?
I do.
You do still? Okay.
I teach and I help with the schedule and I help with protocols.
But you did that for a long while, right? Where you were doing the books and everything and doing it.
Right.
So was it the payer mix? How did you stay in business, accepting all these loans? Because that's the fear, right? Is that you won't make profit, you won't be able to stay in business if you start accepting the Medicaid patients.
I think initially, I saved up a lot of money when we first started. As an ER doc, I saved a lot of money up. And so I didn't need to get a bank loan. Yeah. And I think the short answer of how we stay in business is by not paying me. Yeah. But I think the long-term answer of scalability, it's something that hopefully can inspire other people to do it if they feel like they're getting their income from other sources. Yeah. I don't know if it's scalable or replicable. Yeah. I don't know if that
hasn't been something that you've thought about or spent time
We did have 4 urgent cares.
Yeah.
And we sold one. Yeah. The one in North City. The one in Eureka we closed down because our staff didn't want to go there, even though it was actually making money. And we still have the one in Creve Coeur. Okay. But I had no desire to expand. Okay. And I felt like if I focus on one thing, I'd do better at it.
So is it the payer mix? You're able to achieve a payer mix?
The payer mix downtown is actually pretty good.
Okay.
Meaning over 90% of the patients have private insurance downtown.
Yeah. Okay.
Also, the out-of-towners, so it might work in a downtown model, it might be replicable because we get over 3 million visitors a year.
Yeah.
And being on a plane is highly correlated with having health insurance. And so you can imagine the vast majority of our patients, when there's a convention or when there's a Blues or a Cardinals game,
Are
going
from
on,
out of town, maybe, and then
have insurance.
They're there, yeah,
and have the ability to pay. And so that might be one way that we've been able to survive well.
Yeah.
So yes, we certainly, the leaner months are the winter.
Yeah.
And the fat, juicy months of the
or
summer.
the summer.
Yeah.
I mean, the replicability is an interesting thing. We're trying to make the Bander Center unreplicatable and
Right.
unique. You know what I mean? But something like that, you would think, if you want to work with us on a project in the future, it might be the replicability of the model. You know what I mean? We're kind of, I keep thinking about
my
that.
ultimate goal is that, and I say this all the time,
Yeah.
and my staff tell me to shut up when I say this,
Yeah.
is if I should suddenly die,
Yeah.
because remember, that was the original reason I started, the whole urgent care will continue, and it will continue fine.
Right.
And I believe we have reached that point.
Yeah.
If you can automate things well, and I think in the electronic age, we certainly can automate a lot of things well.
Yeah.
I think it would continue, and it would flourish even without me. I think.
Right. Did you have a problem getting providers to work at 2 a.m. in an urgent care setting, which there aren't all these people competing for that space, right? So, how did you do that? Did they get into the mission, or how does it go?
So you're kind of touching on a trade secret. But,
okay.
I will say that all our doctors are, including the ones who work at night, are very dedicated.
Yeah.
And they have to be.
Yeah.
And I do interview a lot of people, and we probably hire maybe 1 in 5 of the candidates.
It's not for everybody, and
It's
plus
not for
you're
everybody.
somewhat selective.
You've got to have a bit of a calling to work for me. I'm kidding.
Yeah.
You've got to have a bit of a calling to
Yeah.
want to do something in an underserved area, and even if it's only for 2 or 3 years.
Yeah. Okay. I'm friends with you on Facebook. I'm glad we are friends on Facebook because I get to read. You have
I apologize.
great posts on Facebook. One of the things you've posted, and I like this idea, and I'm pretty sure there aren't very many people talking about this idea, but is that, do people have a moral obligation to receive their health care at institutions that serve the low-income, underinsured, and uninsured population?
So this is an issue that I do discuss quite a lot. And I think I'm trying to put socioeconomic discrimination in the same category as any kind of discrimination. Whether it's racism or homophobia or anything. And so most what I would call right-thinking people, obviously we can't generalize, but I think we can on this one, most right-thinking people would not visit a business or service if they were discriminating against people of a certain color, or if they were discriminating against people who had a different sexual orientation from them. And I'm going to guess that most people watching this would probably say, yeah, I wouldn't go to that place. So it's not so much of a moral obligation, but would you go to a place which denies the poor?
Right.
Would you go to a place that delivers great services or products? And I'm not just talking about medicine, but if they deny the poor. Now, I think it's fine, and I'm going to put my capitalist hat on right now. If you're going to buy a fancy pair of shoes, or if you're going to buy a fancy car, or if you're going to go to a fancy restaurant, then obviously they do discriminate against the poor by definition. But if you're going to be talking about the delivery of healthcare,
somehow it's different.
Or the treatment by a judge, which isn't really a service, but it's something which, when you have private prisons, it kind of is a business now. Then I think socioeconomic discrimination unfortunately exists, and it's rampant. And the wealthy are perpetuating it by not putting their foot down and saying, I don't want to be part of this unless you treat me like somebody who is poor.
Yeah.
So one of my doctors, actually, I won't name him, is he wanted to get off his shift early because he had to go to court to contest a $250 speeding ticket. And I said to him, in England, we can't do that. If you get stopped for speeding, you get points on your license. You can't pay it off.
Right. Yeah.
In this country, you can speed if you're rich.
Yeah, right. Yeah, right.
And so I'm like, I don't agree with that. I think that everybody should get treated the same for doing something which is detrimental to public safety.
Yeah.
And so so the rich guy can get away with speeding.
Yeah. So some of the ethical decision making is like where to draw that line.
Not that my doctors are rich.
I know, right? Where to draw that line? Where you can discriminate socioeconomically in certain realms, like luxury goods, right? You might say everybody say that's okay. You know what I mean? But
fine.
you start getting over into something like healthcare. You might draw that line, but where that line goes might be something that people would disagree on.
So if you are, getting to your point, if you are operating a facility, whether it's for-profit or non-profit, which accepts the lower echelons of payers, then your survival is dependent on the haves, the higher echelons.
Yeah.
And if they don't come to you, you're going to go down. You're going to go under. So it's only because the wealthier folks come to downtown urgent care that we are able to provide for the less wealthy folks.
That's interesting.
And if the wealthy folks stop coming, I don't think we could survive.
Right. What's in store for you next? I mean, have you I thought you given up the leadership of downtown, but you're still involved with it. You know what I mean? But do you have future projects like this in the works, or it's a secret, or it's not yet totally devised? Or how's that?
I'm one of those people who believes in the battle, believes in the project, believes in always doing something. Otherwise, I'm bored.
Yeah.
And I do have a lot of projects in the pipeline. And as you get older, I used to be, I still am, I think, a wild one. And I used to have probably way out in left field, I think is the American term, ideas on doing things. And I still do, probably. But as you get older, you become more risk averse, right? And so, because you're thinking, oh my God, if I end up, penniless, that's not good when you're 60 or 70. It's probably more easy to tolerate when you're 20. And so so you start taking fewer risks.
Yeah.
And so I do have a lot of projects. Nothing that I would probably want to share right now. I am interested in the cannabis legalization, as long as it's in a controlled fashion, like alcohol and cigarettes.
Yeah.
I think that's something that's piqued my interest.
Okay.
I think it does help a lot of disorders, and I think it is also capitalist and socialist at the same time.
Yeah.
And it also appeals to both sides of the political spectrum. So that's something that's of interest. I have no interest, because I don't even know if this was on your mind, but because of the number of people who asked me, I have no interest in running for any kind of public office.
Oh, really? Okay. Yeah, we were wondering.
So,
right. About that.
I think on the subject of healthcare, I think there's a lot of politicians who say a lot of things, and they do sound bites, and they mistaken things, or they oversimplify things.
Yeah.
And I think that's what probably politicians do about everything. And I don't think I could survive or be happy in that kind of environment where
everything is in short little fragments.
Everything, things are a lot more complicated, and you're really just appealing to the masses and mob psychology, rather than the truth.
Yeah.
And I think that's what I seek.
Yeah.
I guess other projects I'm working on is meditation spaces and mindfulness and yoga and developing spaces for that.
Interesting.
For people, but that's another project
Cool.
for another time.
Another time,
And I think I get excited about that.
Neat. Would it be okay with you if we opened up to the audience for some questions, or
As long as they're not awkward questions.
any commentary, or I mean, does anybody want to respond to what we talked about so far, or pose a new question or introduce something new to the conversation? If there is. Yeah, right here. We have a microphone, so let's do the mic.
With all of the 2020 stuff ramping up, and with candidates talking about universal healthcare, talking about your sound bites, right? Universal healthcare for all. You had mentioned a few times about this complexity of capitalism and socialism type ideas together. Could you speak a little bit more on, with your thoughts on how, is there anything that you've been hearing that sounds possible or exciting to you in that area of conversation? And is it even possible in our current culture, which is much different than another country, for example?
Great question. I think the answer is yes. I do believe it's possible. If you look at what the average American pays in taxes, and you add to that what the average American pays in health insurance premiums, it exceeds the average tax in a socialized country. So we're already paying for our healthcare. To me, that's the math. It doesn't actually have to get, I'm sorry for that soundbite. That's the math. If it's actually going to be cheaper for us to look after all 300 million people with a slight increase in taxes for the wealthy and no increase in taxes for the majority of people, I think it's completely possible. And I think we spend a lot of money. I'm not going to talk about wars and certain weapons and things that we buy, which somebody said to me the other day, the funny thing about nuclear weapons is that we don't even know if they work. And so, we're spending billions and billions of dollars on maybe the wrong things, and maybe the right things, maybe that's fine. But maybe we should have a sense of priorities and put the healthcare of the people first. I do think it's possible. I don't see why it's not possible. What I do know is that, they made the same argument against Social Security 100 years ago, and against Medicare 50, 60 years ago. And now we're hearing this. And, I do believe that universal healthcare will become a reality in my lifetime. It might be when I'm 80, but hopefully it'll be when I'm 55. And not because of me. I think, I and my family we're fine financially. I just think that people like us and richer than us who should be caring about the poorest people. I just think it's a travesty that it's not happened so far in America.
Do you have a follow-on to that? I do, if you don't.
Yeah, go ahead.
I was thinking, so say we achieve some kind of a universal health care, right? Downtown urgent care wouldn't need to exist anymore, right? Because everybody would have the card and could go anywhere you want. You maybe the 24 hour, 24/7
hopefully they'll still come.
Still come to you. Yeah, exactly. But something where you need to. I like the model. That's why I have you on the show.
I do want to say that
the model of the payer mix and serving the underserved.
Right. I do think American healthcare is fantastic.
Yeah.
And I do think American medical research is the envy of the world. But even with all of that, how come on the CIA website, cia.gov, the USA is number 43 in lifespan out of all the countries in the world? Why is that the case?
Yeah. Why could that be?
To me, that's just crazy.
Yeah.
It's like spending a fortune on your kids to go to college, and they just keep dropping out of everything. That's how it feels. You know, and it's like we've spent more, and we do spend more, exponentially more than other countries. And we're number 43 in our class.
Yeah.
You know, to me, that's like insane, you know.
No one can figure that out.
Well, I think the answer is obvious, but.
Is there another one? Yeah.
Hi, thank you for being here. So kind of following up with that, we were actually, I'm in the MPH program, just down the street. We talked a little bit about that within the scope of our class, like in this current semester, as far as like, we spend so much money on healthcare, but you know, our lifespan and these health outcomes that we look at all of the time are so abysmal in comparison to some of these countries whose healthcare spending per capita is so much less. And I know our solution to that was, well, we don't spend nearly enough money on preventive measures, and we don't spend nearly enough money on like, you know, primary or primordial, you know, health interventions, and trying to think of these things in terms of what can we do instead of having to like take care of all these people once they're sick. What can we do to make it sure that people aren't getting sick in the first place? So I guess my question and thinking of in terms of universal healthcare, and you know, I do agree, I think it's completely feasible within this lifetime, but where do you think that falls if we start shifting the way that we spend money on healthcare in the US? Where do you think that prevention falls?
That's a great question. So one thing, I didn't answer your question when you asked me to define downtown urgent care. We don't just do urgent care 24/7, we do primary care 24/7. And a lot of urgent cares don't, and I don't know why, well, I do know why, I'm just being diplomatic, don't refer people to a primary care provider when they leave. So if you were only working for profit and you were seeing sprained ankles and runny noses and people getting sick, do you want them to come back, or do you want them to go to see a primary care doctor? And so, unfortunately, there's a bias built into the system where they want them to come back. Next time they have a problem, they don't want them to go see a PCP. They want them to come back. So they don't refer them to a primary care. So prevention is vastly better than cure, and cheaper than cure, and so much more logical. But I've not seen this. So I'll give you the one example of asthmatics. So in the socialized country where I grew up, socialized healthcare system that I grew up in, every asthmatic was very familiar with a peak flow meter. And they knew what their numbers should be based on their height and their age. And I came over here and I was trying to educate all the patients I was discharging about peak flow meters, which strangely were not covered by insurance. Strangely, you can't even find them half the time, whether it's in Walgreens or in your own hospital. And I mean, St. Luke's very kindly and maybe out of pity for me bought hundreds of them so that I could keep dishing them out to people and educating people on how to prevent a future asthma attack, because your peak flow actually falls typically 12 to 24 hours before you have an asthma attack. So you check it every morning and you don't have an asthma attack because you take an additional steroid, or you call your doctor and maybe you get you know, a different kind of beta agonist or something like that. And so the prevention side is so often neglected, not just in asthmatic, but in so many things, because that diminishes the profit side. And so prevention and profit are unfortunately inversely correlated. In a universal healthcare system, the goal is not profit, the goal is outcomes. So it's all about prevention, prevention, prevention. The bottom line is that healthcare should not be a business, in the sense that a business is defined as a profit-making enterprise. And so, yeah, I would love it if downtown urgent care shut down because we had universal healthcare. Yeah. But I don't think it's going to be that easy to get rid of us. I think it might be 100 years before you get that. But you know what? Even in socialized systems, in England, for example, and I know this to be a fact in Australia as well, you actually can have a two-tier healthcare system. So if the wealthy do want to get seen by, you know, a place which has private rooms and a TV in every room and nice and valet parking and free Wi-Fi and nicer food, and I can give you a whole list, and a helicopter pad, and all those things which have absolutely nothing to do with good outcomes and good healthcare. But this is how people choose their healthcare. then they can do that. They can pay for it. And a lot of them will pay for it. If you're a gazillionaire, you can pay for it. Sure, go for it. Knock yourself out. Actually, pay your taxes, go to your private healthcare system, be less of a burden on the public system. Better for everyone. Better for you, better for the poor, better for everyone.
What do you think?
No, yeah, I mean, I think, so my answer to that would be, yeah, I think that it's not a lack of resources. I know we talked about this specifically with the city-county merger that is, potentially impending, where there's this fear that if we give things to other people, there's not going to be enough to go around, and this is something that I've heard echoed by a lot of my professors. There is enough to go around. We have enough to go around, and there's just this fear that if we are selfless in that endeavor, especially I think with things such as healthcare and access and resources. So I guess I think of it in terms of finding a way to forge those avenues and build those partnerships between constituencies that are, you've got your public health professionals who know what to do, but you've also got, people who want to make a profit. And so they're like, well, if I take care of people before they have problems, who's going to come to me when we have problems? I think of with Head Start, I worked with them with asthma prevention and trying to get them connected with resources. And there's all this plethora of resources for public health in St. Louis, especially with asthma, since we have such poor asthma outcomes for our children. But yeah, it's just that we have this lack of knowledge. So I think that that's really insightful.
I don't think you need to be all kumbaya and a hippie or whatever the euphemism might be for saying that everybody should be looking after other people's problems, because I've heard the counter argument that I've looked after my health, I work out, I don't have too much salt, I don't smoke. Why should I be looking after that guy who's obese, not you, that guy over there, who's obese, who smokes, who doesn't look after his health, who never works out and eats the wrong food, and then when he has his heart attack, why should I be paying for him? So I've heard that argument. So the first thing that comes to mind is this other people thing. Firstly, that guy is probably the minority of people, meaning the guy who doesn't look after himself. And partly it's because of lack of education and awareness of what to do. I've had people who are college graduates who did not know that smoking was bad for them. And I thought they were joking. I'm like, what? I'm like, you didn't know smoking? Okay. So it makes me think that what about those people who've got much lower level of education? What do they not know? And so I think part of it is education. And then back to the argument about looking after them, other people, and how we're going to make a profit. If we can convince the profit mongers that there actually is money to be made in doing a good job. In other words, you speak to people on the other side of the aisle, and you speak the language that they speak, which I do believe I speak, and that's why I call myself a capitalist and a socialist, and I think the two are reconcilable. Difficult. It's a very difficult marriage, but it's possible. I think you can actually win hearts and minds, which I know is very difficult, especially in the politics that we've seen in the last few years. People think changing hearts and minds is next to impossible. Nobody ever changes their mind. But I think if you speak to people in their own language, and they don't. I mean, I hate labeling people as left-wing, right-wing, socialist, capitalist. That's why I'm like, because all of us, I mean, raise your hand if you're extremely left-wing or extremely right-wing. Either one. Anybody? Right, okay. So part of you, I guarantee it, probably has a right-wing tendency on something. And so there is no clear demarcation as much as we like to think there is. We may not like the way some people do some things or say some things, but I think you can probably, if you listen to that inner voice, there are some things that you actually do find yourself agreeing with. You'd never admit to it openly, but you do say, I see what they mean, but I'm never going to tell them that I see what they mean. But if we do speak to them in that way, then they're more likely to come over to our side.
Fantastic. Thank you, Sonny Saggar. Yeah, very nice.